Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thanks for listening to Behind the Knife. This is Jason here. If you're prepping for the complex general surgical oncology boards or just looking to level up your surg-onc game, you need to check out our surgical oncology board review. This isn't some lame review with just flashcards and outlines. We've created comprehensive high-yield scenarios covering the most tested diseases, plus expert commentary and updated guidelines that actually stick and are proven to help you pass the boards. Breast, pancreas, sarcoma, you name it, we've got you covered. We're also thrilled to announce that access to our highly anticipated oral board simulator is included with your purchase. Build real-world confidence by practicing your responses out loud against high-yield, high-pressure clinical scenarios. Available on our app, so you can review anytime, anywhere. Group discounts are available. Enjoy the episode and dominate the day.
Hello, everyone, and welcome to the Behind the Knife mini-series on Operative Standards for Cancer Surgery manuals developed through the American College of Surgeons Cancer Research Program. The Operative Standards for Cancer Surgery Volumes 1, 2, and 3 offer concrete, evidence-based recommendations on cancer surgery techniques critical to achieving optimal outcomes. 15 disease sites were covered in these 3 volumes, and standards for additional disease sites are in progress. Select recommendations from the Operative Standards for Cancer Surgery have been incorporated into the 2020 Commission on Cancer Accreditation Standards. My name is Morgan Jackson. I'm a general surgery resident at the Detroit Medical Center and Wayne State University in Detroit, Michigan.
We are also joined today by a few members of the Education Committee for the Cancer Surgery Standards Program, who are also Hepato-Pancreato-Biliary surgeons. Myself, Dr. Eliza Beal from Karmanos Cancer Institute and Wayne State University, Dr. Daniel Nelson from University of Tennessee Health Science Center, Chattanooga, and Dr. Tran from MD Anderson Cancer Center. The goals of this podcast are to provide education about the standards, generate discussion, and offer technical pearls to both oncologic specialists and general surgeons, to all of whom these standards apply.
Thanks. We are joined today by our guest, a very special friend, Dr. Alice Way, who's a Hepato-Pancreato-Biliary surgeon at Memorial Sloan Kettering and associate professor of surgery at Weill Cornell School of Medicine. Dr. Way contributed to the development of the operative standards for HPB surgery.
Dr. Way, can you share some of the background on the manuals, maybe specifically as it relates to HCC, and kind of describe the process for deciding which standards were included for the HPB section of this?
Yes, so I thank you very much for having me today. I want to just thank Morgan for introducing some of the sort of overarching goals of the operative standards. But really what we're trying to do with this standard is provide people with a technical toolkit of surgical techniques, which are really based on evidence-based methods that are cancer specific, right? So they address things that may not be addressed in patients undergoing this liver resections for non-cancer or non-HCC reasons. And the way we addressed it for HCC, where the principles are a little bit different than colorectal liver metastases, is we assembled a group of surgeons with specific experience in HCC, which included not just surgical oncologists, but also liver transplant surgeons who take care of patients with HCC, as well as medical oncologists and other people who take care of HCC like hepatology. So with that, we separated the questions that were of importance and then did an environmental scan of the best quality literature and try to populate the information, the content of the guidelines based on that kind of information. So high quality information with experts in the field.
Great. Thank you so much. So moving into the guidelines themselves, to summarize the recommendations for operative standards in liver resection for hepatocellular carcinoma, the first standard is that the surgeon should perform a thorough inspection of the liver and abdomen, either laparoscopically or open, and secondly, should resect all lesions to macroscopically negative margins. These are both strong recommendations, but they are based on low-quality evidence, including retrospective reports, case series, or case control studies. Dr. Way, what is your approach for systematically evaluating the liver and abdomen for lesions? And how does it differ when performing a laparoscopic or robotic versus an open resection?
Yeah, so I do think it's important as the very first step for any cancer operation to evaluate the liver as well as the surrounding structures to make sure that the indications for surgery are correct. So when I put in a camera or at laparotomy, and I don't think they're fundamentally different what you do, you want to make sure there's no evidence of extrahepatic disease that would change what you would do. You want to make sure that the tumors that you see correspond to what you expected preoperatively. And if they are different location or larger, that you adjust the plan to be appropriate. And you also need to you need to sort of evaluate the non-tumor liver, because that's a situation where all the tests that we have so far can be imperfect. So we want to look at the size of the future liver remnant, the quality of the future liver remnant. So that means, is there fatty liver disease? Is there fibrosis? Is there cirrhosis? And does this correspond with your preoperative evaluation, or is it worse than you might expect? And then you want to also make sure that that future liver remnant, which is the part of the liver you're going to leave in after surgery, has adequate inflow, outflow, and bile duct drainage. So those are the things I would systematically do, whether or not it's minimally invasive or open. And I don't think it necessarily matters. So that's really the very first step. I think we also need to do an ultrasound, but at least the very first step is to do a visual inspection and make sure it corresponds with what you anticipated.
Awesome. Thank you so much. And then a little bit more detail, how do you select patients then who are better candidates for a minimally invasive resection versus starting as a laparotomy?
So I think it depends, of course, on your familiarity and your comfort level with doing minimally invasive surgery. As many of you know, that there is different levels of difficulty for MIS surgery. You want to make sure that if you're doing a minimally invasive approach, and most of us are now doing robotics versus traditional laparoscopy, though they're both very good, that you want to be able to make sure that you can respect the principles of the surgery are there. So usually for hepatocellular carcinoma, we aim to do an anatomically based approach. So whether or not that's a formal major hepatectomy, so a sectionectomy, but also if you want to do a segmentectomy or bisectionectomy, right? So these are smaller but anatomical units of approach. If you're able to do that minimally invasively, I think you can do it minimally invasively. When would I do an open approach? In patients who've had extensive prior surgery, perhaps, though I think you can be successful minimally invasive as well. I would also do an open approach if I felt that the tumor could not be visualized or identified or localized with the MIS. So, for example, a patient with a small HCC on the background of a highly dysplastic liver with a lot of regenerating nodules, that's a patient in whom I might choose an open approach rather than minimally invasive approach, mostly because I'm worried about localizing the tumor accurately at the time of surgery.
That makes sense. Thank you so much.
So in addition to, carefully reviewing high quality preoperative imaging, these guidelines emphasize that intraoperative ultrasound of the liver is the current standard for intraoperative HCC staging and evaluation. Major structures, including the hepatic vein confluence, portal vein divisions, and associated bile ducts, should be located, assessing distance and relationship to all lesions. In your training and then practice, how did you gain experience performing and interpreting intraoperative liver ultrasound?
Yeah, so intraoperative ultrasound is extremely powerful for all liver surgery, and I would say it goes beyond HCC staging. It should be used for anybody who's having a liver resection for any reason. How do you gain proficiency? So you can do it in many ways, and I would say you should do it in multiple ways. First of all, there are some courses that you can take. The AHPBA runs a course. Many other associations run a course on intraoperative ultrasound specifically to learn the principles of intraoperative ultrasound. The other thing is that you should have it available to you for every case and ultrasound the liver whenever you have the opportunity to, so that you become familiar with the normal anatomy and what to anticipate, right? So in every operation, you can pull an ultrasound and look at the inflow, outflow of the structures, even if you're not using it for specific localization procedures. The other thing is that we actually get access to a lot of ultrasounds that we don't look at. So, for example, when patients come to see me in clinic and have an outpatient ultrasound, I actually pull up the images and I look at them because somebody, an ultrasonographer tech, has actually done, like this kind of very standardized sagittal, cross-sectional, longitudinal imaging and marked all the major structures. So you can actually use that as another training tool to look at it. But I do think it's extremely powerful. It's very, very nuanced. So I think you have to practice it a lot and you have to use it whenever you can. So that's what I would say. My training and practice, I do it all the time. And I still think I'm getting more sophisticated the more I practice.
Thanks. Do you routinely use an adjunct like ICG or methylene blue during your liver resections?
Yeah, I do. So particularly for MIS, but even growingly for open surgeries, I will as well. ICG, for those of you listening who may or may not be familiar, is a fluorophore that you can use for many purposes. But if you want to use it for the bile ducts, you need to inject it about 20 to 40 minutes prior to use so that it can be processed within the liver and excreted in the bile ducts. The other way that we can use it for liver surgery is not just for bile duct visualization or biliary visualization, but for vascular visualization. So you can, I would sometimes use it not so much for the bile duct anatomy for a major liver resection, but in order to do something called negative staining. Whereas when I take the inflow, I then give the ICG, and then the part of the liver without flow will not have ICG, and then I'll be able to see the transection or parenchymal margin. So there's lots of ways to use it, but I routinely use adjuncts whenever I can. Before we used ICG in the quote unquote old days, which is really old, we used to use methylene blue sometimes with direct portal injection. That's a very Asian method. And so there's many ways to do that, but I think you should be using these things particularly for HCC, where you want an anatomic resection whenever you can.
Dr. Wei, real quick, with regards, there are places where people will pre-inject ICG like 3 days before for colorectal liver mets and for HCC to try to localize the tumors or get the ICG to concentrate in the tumor. Is that something that you do, or do you find that helpful?
It's not something that we do in North America. I do think it's something very standard that's done in Asia because they're using ICG to also assess liver function prior to surgery. I really do think it can be helpful. It's not something I have direct experience with now. I really think we're in the infancy of seeing fluorophores help us localize anatomy and tumors. So in the future, we'll probably be doing this more often. Right now, we just don't do it because of logistical constraint, which is that it's hard to give ICG in the clinic, in the outpatient setting.
Okay, thanks so much for that. Let's jump into a little bit of the technical elements, if you don't mind. As somebody who does a lot of robotic surgery, I know. Can you walk us through the steps of performing a robotic-assisted right hepatectomy that meets the operative standards?
Yep. So thank you for asking me to do an anatomic resection. It's much easier because, of course, that's really part of the principles of HCC surgery, which is really different from other diseases like metastasectomies, colorectal liver metastases, which many of the listeners will have experience with. So for HCC and a patient who requires an anatomic resection for right hepatectomy, the most important things, I think, for all MIS surgery, and I think everyone who does MIS surgery knows this, is positioning. So for robotic right hepatectomy, I'm very careful to position them in a sort of sloppy decubitus position. I bump their arm up with a Gallagher bar, and I make sure that they have a steep reverse Trendelenburg. We put in the ports. The first thing I do with laparoscopy, right, is I do a visual inspection and I make sure it's dictated in note, because I think it's really the key for for oncologic surgery, is to make sure that what I'm seeing, there's no extrahepatic disease, there's no evidence of peritoneal disease, there's no additional metastases that I see, and there's no evidence of worse portal hypertension or cirrhosis than I anticipate. Next thing I do is I localize the tumor. So I put an ultrasound on the liver and I visualize the anatomy, make sure the tumors where I expect it to be, make sure it's the size I expect it to be. And then lastly, I look at the anatomic configuration of the liver to make sure the anatomy of the liver, the inflow and outflow, is as I expect. Are there any variants in the hepatic inflow, the portal inflow, or the hepatic outflow, so that I can plan my procedure? And then just one pro tip I would give the audience is that if you see variation in the anatomy, you should have your spidey senses up that there could be more variation than you anticipate. So hepatic artery anatomy is quite variant and can be variant without biliary or portal vein anatomy. Biliary anatomy is the second most variant. Portal venous anatomy is the less variant. So if you have portal vein abnormalities, you should have your spidey senses up that there could be concomitant biliary tract anatomy. So that's the kind of ways that we start. Once we have done exploratory laparoscopy, make sure that make sure there's no extrahepatic disease and confirm the operation that we're doing, then I get inflow control early, right? So there's a couple ways to get inflow control. I tend to use an intraglyconian approach, a very classical approach. I open the glyconian capsule, take the hepatic artery to the right, take the portal vein to the right, and I divide them. I then give ICG, very low dose, so you can see the difference between the green stuff, which still has arterial blood flow, which is the future liver remnant, and the stuff which should not have ICG, which should tell me the transection line. For right hepatectomy, it would be Cantilly's line. I don't take the outflow yet. I take the outflow intrahepatically, and then I do a parenchymal transection. I use the ultrasound all the time to mark the anatomy throughout the case, to make sure I'm in the right place, to make sure I'm not getting confused about where I am, and to make sure there's an adequate margin on the tumor. And then I transect and take the right hepatic vein intrahepatically, making sure not to injure the tumor, make a hole in the tumor. These are soft, fleshy tumor, and ensuring there's an adequate margin. I will do a selective lymphadenectomy. So for HCC, because the lymph node staging does not change the long-term role for adjuvant therapy, at least at this time, our operative standards do not require lymphadenectomy for staging on all patients. So I do it selectively if the lymph nodes are enlarged and if they're concerning. But I do not do it standardly for everybody with HCC.
Okay, thanks a lot. And so I assume you march along the middle hepatic vein as kind of like your landmark for a right hepatectomy. For a left hepatectomy, tell me a little bit about where your ports might differ and how your positioning might differ. Yeah.
Yeah, so a left hepatectomy, I would say, is a more straightforward operation. These patients are split leg supine, so I use the French position, so the physician assistant or your assistant can stand in between that. But you're absolutely right. What Dr. Tankau said is absolutely right, is that we would typically mark the middle vein so that our transection margin will be selected either to be medial or lateral to the middle hepatic vein as appropriate. That's really the secret to a major liver resection. For a left hepatectomy, it's a little bit easier because the inflow is it's a bit longer and a little bit farther away from the main portal vein and the common hepatic artery. So the left hepatic artery is usually easy to take. The left portal vein is long and extrahepatic. I usually take at the base of the falciform. And then the same thing, I'll mark with ICG after the inflow is taken and then I go along Cantilly's line. For a classical left, I will go to the patient's left of the middle vein. The one thing I will mention is that I always set up for a Pringle maneuver, whether or not you need it or not, depends on the case. But I think as a safety move, you always want to have it available to you so you have adequate inflow control if you need it.
And then maybe last set of questions from a technical standpoint. When you're dealing with a patient who has cirrhosis and or portal hypertension, what particular considerations you take in addressing them surgically?
Yeah, so for these patients, you have to be much more careful about parenchymal sparing approaches. I would do everything possible to do the smallest anatomic unit that would be appropriate to get their tumor out. I think the other thing that you'd be careful about with people with cirrhosis and portal hypertension is I think these patients benefit much more from an MIS approach because you don't disrupt any collaterals they may have that are going through the anterior abdominal wall, for example. I'm also super careful about making sure that the anything that could open up, like for example, ligamentum teres, is sealed very, very carefully, and that because it could open up after, and just be very cognizant of all the collaterals they may have. So for those patients, although there haven't been a lot of randomized trials, but we do know from multiple case series that patients with cirrhosis may benefit more from an MIS approach than an open approach. And I think these patients are very good candidates for that.
Thank you very much. That's a great point.
Great. So moving on to the second guideline, which is to obtain macroscopically negative margins. The operative standards do specify that a Gleasonian pedicle-based or anatomic resection is preferred over a non-anatomic resection due to the risk of intraportal metastases. If you are performing a non-anatomic resection, the gross margins should be at least 1 to 2 centimeters. Dr. Wei, what do you find are the benefits of performing an anatomic versus a non-anatomic resection, and how do you weigh the importance of pedicle-based resection with maximizing functional liver remnant?
Yeah, so I do think I tried to address that a little bit earlier. I think for HCC, really doing an anatomic-based resection is something we should try to aim for. The importance of it is that you can be extremely refined if you do a pedicle approach, saving actually the most liver, right? Because for these patients, so for example, if they have a segment 7 lesion, by taking just segment 7 or just segment 8, in many ways, you might save more functional liver than doing a large, wide local excision with at least 2 centimeters all the way around. I think it's something we're not as familiar with in the United States because so much of the liver disease we do is for colorectal liver metastases. But I do think with the MIS approaches and even with the open approaches that's something we're becoming more familiar with.
Great. And then do you ever have to change your approach in the operating room based on the identified tumor location and the intraoperative ultrasound? Does that ever change your approach between anatomic or non-anatomic resection?
Sometimes I think you have to be flexible, right? Like you want to be safe for the patients and you certainly want to try to do it. I do think some patients, for example, like if they have a tumor that sits in between the Gleasonian capsules, which is actually quite unusual for HCC, but let's say it bridges 2 and you have to do a bisectionectomy. In that situation, you might move to a non-anatomic approach and just do a wide local excision for the patients. So I think you want to be flexible for the patients if you need to, and save as much future liver remnant as you can. I don't typically do frozen sections, but I really will try to use the ultrasound to guide an anatomic approach. And I think this goes back to what we said earlier. I do think ultrasound is exceedingly powerful, and I think that we should all aim to try to get familiar with it and use it, even for colorectal liver mets, so that you can really be very selective on where you're cutting.
Thank you so much.
Dr. Wei, you mentioned the lymphadenectomy earlier. I was hoping you could kind of expand on that a little bit. Is your management of portal lymph nodes different based on histology? Like, does it differ between a hepatocellular carcinoma and, say, a fibromedullary type?
Yeah, so I think lymph node sampling or staging is actually really important for all cancers where it's important. That sounds ridiculous. But basically, I think that you want to adjust the operative standards for the disease that you're treating. And just to be very simple, if you're doing an adenoma, you don't have to do a lymphadenectomy. So lymphadenectomies are really in the domain of cancer surgery, right? So for cancer surgery, I think you need to know why you're doing the lymphadenectomy. Is it therapeutic, or is it staging, or is it both or neither? If it's neither, you probably shouldn't do it. If it's both, you should do it all the time. But I think it's just important to know those principles. And I actually think that's what's some of the terrific things that is important for the operative standards, is to clarify and make explicit to the community like us why we're doing it and if we should do it. Because of course, lymphadenectomy sounds easy, but there's always the possibility of injury. And there's also the possibility of doing it not well, right? like, lymph node sampling, do you just take the cystic duct lymph node? Well, that probably is not enough. Do you strip it all the way down? Do you do a portal lymphadenectomy? Do you do all the way to the celiac? So you kind of have to know what you're doing for it. So I would say it matters. For HCC, it doesn't seem to affect either staging or adjuvant therapy at this time. But if adjuvant therapy becomes something that we are routinely recommending for HCC, then I would do it if lymph node status affected adjuvant therapy. So I think it's just important to know the principles.
And just kind of going back to making sure that our listeners are aware of the guidelines, wanted to clarify that in the Operative Standards guideline, only patients with histologically positive or radiographically enlarged portal lymph nodes should undergo lymphadenectomy at the time of hepatic resection, and that lymph node sampling is not recommended in routine cases without preoperative suspicion of lymph node involvement.
Right. Yeah. And I think if you have patients in the operating room with frankly positive nodal disease, then I think you want to just take a pause and try to understand whether or not the liver resection that you're aiming to perform is going to benefit the patients or not. And that's where something, where there's a lot of nuance to that. For example, if you have a patient with a 15 centimeter tumor that's at risk of rupture or has ruptured, in that specific situation, liver resection with or without lymphadenectomy may be appropriate. Whereas if you see someone with a small, you know what I mean? I think lymph nodes are relatively sophisticated, but they're not routinely recommended at this time. They could change with evidence. And I think the operative standards would change with them if adjuvant therapy showed that lymph node status was something that affected whether or not patients should have adjuvant therapy or not.
All right, thank you so much. So that is all that we have today for the HCC portion. As a trainee, the operative standards outline critical steps for operative techniques and essential elements to address in oral board scenarios. Additionally, residents are often tasked with initial documentation, and these synoptic operative elements need to be included within the operative report. If you're interested in learning more about the cancer surgery standards, please visit the Operative Standards Toolkit on the ACS website, which is linked in the show notes. Additionally, excerpts from the Operative Standards for Cancer Surgery, volumes 1 through 3, are included in each of the Commission on Cancer's Surgery Operative Standards.
Thank you again, everyone, for joining us. And please catch upcoming episodes in the coming months regarding more operative techniques for cancer surgery.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple iOS and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.